everyone. My name is Alyce Adams. I'll tell you a little bit about me before I get started in talking about the talk so that there'll be some consistency. You'll understand where I'm coming from today. So over the last 25 or so years, I have been studying why it is that even when people have health insurance in the United States, we still see marked disparities in healthcare outcomes, particularly for chronic conditions like cancer. So what does that look like? It looks like Blacks and African Americans, for example, having much higher death rates from breast cancer, far beyond what would be explained by insurance status, when they got treated, or who's treating them. I'm talking about disparities in rural communities, for example, rural indigenous communities, where people have to travel 2 and 3 hours to get basic care that we take for granted in urban areas. I'm also talking about lower income and lower education communities who have been disenfranchised for numerous reasons in terms of accessing care. The reason I came to a place like Stanford 3.5 years ago in the middle of the pandemic, like square in the middle of the pandemic, was I was really excited to come to a place where people are excited about research and science for the betterment of society. I was excited about coming to a campus where I could feasibly collaborate with epidemiologists in one part of the campus, engineers in another, as well as sociologists in another part of campus, to really try to understand some of these disparities and address them. And then finally, I was convinced that the leadership here, both of the healthcare system, but also of the university, are committed to Stanford becoming a leader in health equity science, if you will. So that's why I'm here. I'm so excited to see all of you. I'm really hoping this is going to be more of a discussion than me here yakking at you. So please do ask questions. When we get to the Q&A component, just as a preamble, there's someone who's going to be coming around with a mic. So our request is that you wait till you get the mic before you speak so that everyone in the room can really participate fully in the conversation. Thanks so much. And with that, I think we should go ahead and get going. So the first thing I want to do is acknowledge the land that we stand on. The Alumni people were here before us. They continue to be here, and they're our partners in a lot of the research we're going to be talking about today. Disclosures, I have no conflicts, but I will say a lot of the work is funded by Stanford University, as I have an endowment as the Stanford Medicine Innovation Professor. We have a large grant from NCI for our Cancer Center, as well as other federally and non-federally funded research grants. And it's really important for me to say, I'm not that kind of doctor. Those of you who grew up with Doctor Who and BBC will understand what I'm talking about. I have a PhD, not an MD. So what does that mean? Is I can't answer medical questions, so if they come up, please talk to your doctor. I cannot help you in that way. I still hope that I am somewhat helpful in other ways, but I'm not that kind of doctor. Okay. So this is sort of a glimpse into what we're going to talk about today. So I'm going to talk about the impact of cancer. I'm going to talk about innovations in cancer, historical and up to date. And then I want to talk about the core of our research, which is really trying to understand how is it when we have all this innovation, we still get these outcomes that are suboptimal, not only for everyone, but particularly for underserved groups. And then finally, what I'm excited about, which is the work that we're doing here to move to a more equitable future for everyone. So cancer affects all of us. Raise your hand if you know somebody, you have it, your family member has it, anyone who has been touched by cancer, raise your hand. It's probably everybody in this room, right? And the reason I do that is because I believe that to affect differences in how cancer affects us, to improve outcomes, we're all going to have to work together. This affects every single one of us. So again, I'm not a biologist, but what I will say is cancer is sort of characterized by uncharacteristic growth of cells that then spread to other parts of the body. So it's something that's not supposed to happen. The body is normally supposed to regulate itself and keep that from happening, but cancer is the case where it happens, and there's the usual standards for addressing it have to be addressed. Sorry, my notes just went away. That's all right. So what I want to say about cancer is that it's a growing condition in the United States. It affects so many people. Globally, it costs billions of dollars. In the US alone, the estimated cancer cost in 2030, I believe, will be $234 billion in a single year. That's 1 year, and that's direct and indirect costs. That's a 34% increase from 2015. Right? From 2015 to 2030, 34% increase in the costs of cancer. And that, again, that includes what happens in the clinic and beyond. And worldwide, generally speaking, more what we call developed nations, those with higher income, higher educational attainment, tend to be more likely to suffer from cancer, primarily because they're not dying from other things, right? So if you look at the world, in places where we see a lot of poverty and a lot of challenges, they die at a much earlier age. Those of us who've been lucky enough to live in these higher GDP societies tend to be more likely to get cancer, but that's not universal. Some types of cancers, for example, like cervical cancer, you do see more frequently in other types of countries. The US, sadly, is leading in cancer mortality. And the cancers that we worry about most in the US, this is not by all of them, but it's breast cancer, prostate cancer, and colorectal cancer. However, or lung cancer, excuse me. There are lots of other cancers that are also on the rise, like colorectal cancer, pancreatic cancer, and other areas. And when you put them all together, and it is like a pea soup, there's so many different types of cancers out there, but when you pull them all together, they really are a particular challenge facing all nations in terms of not only financially, but also just what's happening to our populations and our workforce as we move forward. So one of the things that we have seen in the last 30 years are dramatic changes in how cancer is treated, particularly in this country, but all countries. And that's due to a lot of different reasons. But in this country, a lot of it really is the influx of technology and advances in technology that allow us to do things we previously could not, and to do things much more faster and more efficiently. But importantly, it's also political will. And what do I mean by that? Well, Nixon passed the first cancer bill back in, I think, 1971. And what that did is it said, let's try to work together to address cancer and break down some of the barriers that had really confined what the National Cancer Institute could do in terms of the science in prior years. It made a huge difference in their ability to push forward on a lot of issues related to the development of treatments of cancer and our understanding of cancer. It also freed up funds to do that. Fast forward to 1993, Clinton reenacted the same law, saying, you know what, we need to keep going, keep our foot on the pedal. We had a lot of progress, but let's keep going in cancer, all the way up into the modern day, which is, of course, the cancer moonshot under the Biden administration. All of these things have catalyzed important breakthroughs in cancer that have dramatically affected our understanding of cancer and how to treat it. So what does that mean? It actually means that what we're doing is pushing forward, not only from trying to sort of keep people from dying immediately, but we're thinking now of cancer as a chronic disease. And we're even thinking, particularly here at Stanford, about how can we address people who have really advanced diseases when they're actually diagnosed, and start thinking about how do we cure those. So it's a very exciting time to be in the cancer space. I just wanted to share a very new video. Dr. Artandi, the director of our cancer center, allowed me to share this with you, but you can also see it on YouTube now. But it tells you a little bit about some of the scientific discoveries that we're really investing heavily in here at Stanford.
Dare to imagine a future where advanced cancers aren't just treated, they're cured. For decades, Stanford Medicine has pursued this brighter tomorrow, uncovering new knowledge, providing care to countless patients, and inspiring the next generation of leaders. In 1956, Stanford scientists built the Western Hemisphere's first linear accelerator to treat cancer, a device that is now foundational to radiation therapy worldwide. Today, we build on this legacy, developing uniquely Stanford innovations that will revolutionize cancer care. A first-in-the-country FDA-approved cell therapy for solid tumors gives hope to patients with advanced melanoma. Our early drug development program increases access to early-phase clinical trials, giving patients new hope in their fight. And work to miniaturize proton therapy systems aims to make this precision cancer-killing technology more accessible. As cancer cases continue to rise, our translation of research discoveries becomes only more urgent. Powered by Stanford Cancer Institute scientists and our community of dedicated physicians and staff, Stanford pushes forward, finding new ways to improve outcomes and deliver hope to those battling complex cancers. Our patients, their loved ones, and the promise of a better tomorrow fuel Stanford Medicine's mission. They inspire our biomedical innovation, our compassionate care, and our commitment to equitable access. Our fight isn't over, but our future is filled with promise. Imagine it with us. Stanford Medicine, transformative cancer care.
So innovations like the ones that Stanford are working on have had a huge impact on cancer outcomes. We've seen this over the last 30 years, starting with the first cancer initiative started by President Nixon all the way to the present with President Biden. We see dramatic improvements in survivorship since 1990, all the way through to the present. These innovations really have fueled improvements in three primary areas. The first being early detection. We can detect cancer earlier. If you catch it earlier, you have a better chance of actually making a bigger impact. Early intervention, right? Getting in there earlier to sort of see if we can really try to reduce the cancer, reduce the tumor, and have a better outcome. And other innovations in care, which have allowed us to take better care of our patients in a more holistic way with larger care teams in an effort to really have better outcomes overall. So that's the great news. Here's the not so great news. Despite all those improvements, despite all that innovation, we still see disparities in outcomes. On the left-hand side, you see breast cancer mortality rates among women by race and ethnicity. And you can, hopefully you can see it, it's a small print, but basically what it indicates is that for Black women, for American Indian, Alaska Native women, and Hispanic women, they still are outpaced in terms of survivorship. They're more likely to die, even with all of these innovations. On the right-hand side, in a similar way, if we look at our non-metropolitan areas relative to our urban areas, they're not doing as well. They're not benefiting as much. Similarly, disparities persist even among the insured. A few years back when I was at Kaiser Permanente, we did a study where we looked at American Indian and Alaska Native people who were served by Kaiser Permanente in Northern California, just to the north of here. And we found that overall, despite having equal access to care, American Indian and Alaska Natives who got care through Kaiser Permanente were more likely to die from cancer. Often what we're seeing ultimately is that patients with the greatest need, patients with the greatest cancer burden are often last to benefit from some of these innovations in care. This is some work done by Truven Health Analytics, recently where they showed the BRCA testing rates. So if you saw before on the historic timeline, I talked about BRCA happening around, I think it was like the 1970s, and then moving forward, really innovating in cancer care. I wanted to make 2 points about this graph. One is, despite the fact that this has been around for a while now, we're really only seeing improvements in people actually having access to this technology starting around 2010, 2012, and that's for everybody. But then when you also further look, you'll see gaps in accessibility by metropolitan versus non-metropolitan areas. I could have showed you any number of gaps by different subgroups, but this one was particularly stark. And the point here is that we're always slow to have innovations result in actual changes in care and outcomes for patients. But what's particularly alarming is that even when everyone improves, we have this sort of persistent gap between different subgroups based on any number of different social conditions and/or economic conditions. So what's going on? Often what we find, again, is that people who have the highest risk of bad cancer outcomes are least likely to be able to access or afford novel therapies. So here you have some startling statistics. Cost of cancer treatment are certainly on the rise. In 2015, it was around $183 billion, $245 billion in cancer care costs predicted by 2030. And patients are feeling the pinch. A colleague of mine, Dr. Benegas, and his team reported a few years ago that about 60% of cancer patients said at some point during their treatment they worried that they might not be able to pay for it, 60%. More than 30% admitted that they had to take on extra debt to pay for their cancer care. And 3% reported they actually went financially bankrupt, primarily because of the cost of cancer treatment. Now, financial toxicity is what we call all of this sort of financial burden of getting treated for cancer. And the particularly alarming thing is it doesn't affect everyone equally. Racial ethnic minorities, adolescents and young adults, low-income people, and those living in rural areas are more likely to be affected by financial toxicity. And I think what gets me the most in my gut is the adolescents and young adults. If you think about people who are felled by cancer that early in their lives, it affects their ability to go to school and graduate. It affects everything after that, right? All the things I took for granted, going to school, going to graduate school, getting my first job, all of those things, they're on a different trajectory if I had gotten cancer when I was in high school, as opposed to being a healthier person. And so really thinking about the impact on those individuals and their families really affects our ability to have a big impact, right, with these innovations if people can't pay for them ultimately. Now, policy is something that I get really excited about. Most people I talk to do not get as excited as I do. However, I hope you are excited about policy, and here's the reason why. Policy matters. It matters because it can either aid or hinder disparate outcomes in the impact of these innovations on cancer survivorship. What do I mean by that? I'm going to give you 3 examples, and then I'm going to go into depth into some examples. The first is coverage expansions, right? Things like Medicare and Medicaid. We know, we've seen it over and over again, that when we make it possible for more people to have access to things, turns out they actually use those things. We see improved access in terms of perceived access to care. We see actual uptakes in clinically effective treatments and reduced cost burden overall for patients. Not everything we do, though, is positive. So one of the things that happens when the costs of care go up is insurance companies and health systems say, okay, how do we avoid paying some of these costs? So one is to pass on some of those costs to your patients through copays. The other is to cut off supply through prior authorization. I'm not sure if people know what prior authorization is. You physicians in the audience, I'm sorry, I'm going to talk about it. But it's frustrating for a lot of people because basically what it is it says you have to get prior approval from the insurance company before you can actually, for example, prescribe something or conduct a surgery or do a specific type of test that you might need. It's intended to reduce cost, reduce waste in the healthcare system. Mostly what it creates is hassle. And it often dampens overall utilization, even when its intent is actually more positive to actually just reduce waste in the system. Finally, copays. When we reduce copays, we have mixed results. For the most part, reducing copays will increase utilization of these services for a short period of time. It doesn't last for a really long period of time, and I'm going to talk about that in a minute. And so that's one of the things we talk about a lot. So again, I guess what I'm going to say here is policy matters, and we have to pay attention to policy if really what we want is to see these innovations get translated into improvements in equity. So the first description I'm going to give, I'm not going to go into these in super detail, but is Medicare Part D. So when I was first graduating with my PhD, Medicare Part D had just been passed, or it was about to be passed. And so Medicare Part D came along because when Medicare was created, it was created primarily to help people with hospital costs. That was the big cost that people worried about. You got sick, you went into the hospital, and then you were in debt because of this hospital stay. Because of all those innovations that we talked about before over time, costs shifted away from the hospital. There's still hospital costs, right? But we're getting better and better about keeping people out of the hospital. But those those services actually cost something, and prescription drugs in particular were on the rise in the 1990s, dramatically so. So in response to that, the federal government actually created Medicare Part D to provide a coverage for prescription drugs that had previously not existed in Medicare. And so what we had done is, I do a lot of natural experiments and evaluate a lot of different policies. And the way that we do that is we say, okay, here's a situation where this is something that was sort of essentially turned on, if you think about it, sort of turning on a light switch or a tap. And what we're able to do is identify people who had really sort of generous coverage before that through their Medicaid program, or not so generous coverage through the Medicaid program. All of these individuals who had Medicaid and Medicare were automatically enrolled in Part D, which meant that overnight, literally overnight, there was a shift in the prescription drug coverage. And so using that sort of torque between those who had generous or not generous coverage, we were able to actually look and see what the impact was across the board in a number of different areas, but cancer was one of those. And in particular, what we were able to see is that initially, some patients, in particular Black and elderly patients, were more likely to be living in states with more restrictive coverage prior to Medicare Part D. And what we saw after Part D went into place was an increase overall in the intensity of use of clinically effective services. We were looking at non-cancer drugs in this particular case, but these were people who had comorbidities that made it unnecessary for them to take these medications. So those who went from more generous coverage to Part D versus less generous coverage, we saw this difference. And most importantly, we actually saw a reduction in previous disparities between Blacks and whites in their utilization of these clinically essential services when they moved from less generous to more generous coverage. Right, so basically if you make it easier for people to get something, that in general they were more likely to use services that were beneficial to them. In another example, this is a prior authorization that I talked about before. This increase in the cost of medicines in the 1990s, and this is actually not cancer specific, but more general for these populations, Medicaid populations. When we saw this increase in the 1990s in prescription drug utilization, a lot of Medicaid programs said, we can't pay for this, we have to do something. And one of the things that they did was prior authorization. In this particular case, Michigan said, okay, if you're taking a drug for the first time, and it's one of these novel therapies that's more expensive, and there's a generic equivalent available that we feel like is more or less equal to that novel therapy, we're going to say your doctor has to get pre-approval before prescribing it. But it's only for people who are new users of the drug. So in principle, it wasn't the worst policy ever, right? It seemed reasonable at the time. And in Indiana, a neighboring state, they did not have the policy, but they were thinking about it. So we had the opportunity to go in, talk to the Medicaid programs of both states, and then work with them to evaluate the policy. And here's what we found. Essentially, the policy had the intended effect. It reduced new use of the novel therapy relative to the older therapy for, in this case, individuals with depression who were using antidepressants in Michigan relative to Indiana. However, what it also did was it disrupted therapy for those individuals who were previously using antidepressants. If we're actually using the novel antidepressants already, some of them came off of those novel antidepressants, even though they were supposed to be exempt from the policy. And most importantly, utilization for all antidepressants, regardless of whether they were novel or not, reduced in the state. So this is unexpected. It wasn't what they wanted. And it turns out, when you looked at the policy, and I looked at it and I had a copy of it, it was incredibly long. And all of the caveats around who was eligible and who wasn't was in tiny, tiny print. And I don't know how many of you are clinicians in the room or prescribers, but the idea that if a very, very, very busy clinician is going to be able to stop, read through the fine print, and figure out for the patient in front of them whether or not they should do this is pretty low. So instead, they just stopped prescribing a whole class of medications for the most part, right? And because of this and because of other studies showing similar results, we saw a decline in the use of prior authorization, but ultimately it mattered in terms of getting innovations out into the community. Finally, the last grouping of policies that I talked about was copays. So back in the 1960s, The federal government wanted to incentivize hospitals to provide more benefits to communities in which they were serving those communities. They felt like, especially those with nonprofit status, they felt like they should be giving something back directly, and we should be able to see that if they wanted to keep their nonprofit status. So as part of the IRS law, they said you have to be able to provide some sort of community benefit. They didn't stipulate how much, nor did they stipulate what you had to do, but as it turns out, the vast majority of hospitals decided what they would primarily do in order to reach this status was to provide care for free. What does that mean? It means if I go into the hospital, I have cancer, I can't pay for it, right? Or I've racked up debt because of it. The hospital can then ask me a series of questions about my income and the amount of that I owe, et cetera, and decide if I fit their categorization. I can't be eligible for Medicaid, but if I fit their categorization of being needy enough, many of them will not only wipe out my existing debt, but they might even give me lower copays for a period of time, or even zero copay for a period of time in order to help me sort of get through my crisis. Most hospitals do this. We have this program here at Stanford, and it's called Community Benefits for Medical Financial Assistance. Well, it turns out people have almost never evaluated these things, but they spend billions of dollars per year for each hospital. So we evaluated, along with several colleagues, some here at Stanford and other places, the medical financial assistance program at Kaiser Permanente in Northern California. We had a very complicated evaluation process that I won't go into, but the long and short of it is we found that the program was successful in increasing clinically effective services among patients who used it. And it even improved the rate of follow-up for patients who, once they got an abnormal test, they were more likely to come back for a follow-up if they got that abnormal test as a result of receiving this service. The caveats here are that lots of patients don't even know about it. So they don't even know it exists. A lot of clinicians didn't know it exists, particularly those working outside of the hospital system. And there were other questions about there's lack of uniformity in deciding who's actually eligible across hospitals, as well as some criticism of hospitals that they're not spending enough. Now we could argue about what is enough, but there's a lot of that in the paper, and you may have seen that recently. But those are just some of the things that different policies have enacted that do seem to help alleviate some of these costs. Now, looking forward, this has really become a focus of a lot of legislation at the state and the national level in recent years. So, for example, here in California, we have a game-changing bill called the Cancer Patients Bill of Rights, which says if you have Medicaid and you get cancer, that you can choose to get care at a comprehensive cancer center. Now, nobody knows how that's going to happen. I was going to say implementation's really tricky, but that was a huge bill, and the idea was to say you shouldn't have to suffer because you're low income and not be able to get the best care possible. That was the idea of it. Many of you saw the Inflation Reduction Act. A couple of things that it did is, one, it addressed directly drug prices. That was actually in follow-up to when President Trump passed some laws related to transparency in pricing. That sort of kick-started some of this work. And then the Biden administration picked it up and sort of moved it further forward in terms of really being able to negotiate, and enabling Medicare to negotiate drug prices with pharmaceutical companies. It also reduces copays for Medicare enrollees starting, I believe it is, next year. So there's a cap on the amount of out-of-pocket spending in Medicare, which is the first time this has ever happened in this country for Medicare. We also know that in terms of prior authorization, there's a lot of pressure on CMS to do something about prior authorization. They actually just finalized a rule earlier this year. In addition, a number of states have been trying to tackle prior authorization, including using AI to reduce bureaucratic red tape, essentially, that happens when you're trying to evaluate prior authorization, as well as any number of other rules around AI and how it might be used in this context. But the policy engine keeps moving forward, and we have to understand all of these different policies are going to have implications for shepherding these innovations to the bench, sort of from the bench to the bedside, if you will, in terms of making sure that people have access to it. So some of the core findings from our lab, and this is sort of some of the work that we do, are the following: that access is necessary for the uptake of novel therapies, but not enough. affordability is critical, particularly with persistence with effective treatments. And that finally, equitable outcomes are never a guarantee. It requires deliberate efforts to enhance fairness, looking at all these different angles from the medical center side, from the policy angle, as well as from the angle of patients and communities. And in particular, we believe that in order to address these persistent inequities, we have to do a few things. One is we have to engage patients and communities in the design of cancer care innovations. We have to take multidisciplinary approaches like the ones we can do here at Stanford to understand the context in which these innovations are actually employed out there in healthcare settings. And we need to leverage novel methodologies to inform the design of more equitable focused policies. What does that look like? This is a quick overview of some of the things that we're doing. So we're actually working with patients and clinicians to drive AI-enabled innovations in cancer care. So what does that look like? For example, right now we're building an algorithm for chemotherapy-induced neuropathy to try to predict it. It's an ongoing study. It's funded by the NCI and other groups, but the most important thing is these are our partners. The people you see on the screen, they're our partners. We have patients who sit with us, with our modelers, with our sociologists, with everyone sitting at the same table to ask questions about how will this help? How do we make sure that everyone has access to it? How do we think about policies that may either aid or hinder its application in the real world? And that's being done with Kaiser Permanente as well. Another example is we're engaging communities in this discussion about community benefit design and medical financial assistance. Because of our prior studies, we've come back and sort of worked with our community to say, well, what could we do? And this map just basically shows that, in summary, that where most of the money is being spent right now for community benefits is actually not in the communities that have the most need. Again, sort of a common story. So how do we shift that? How do we change it? Well, we're working with patients. These are students that we've been working with over the last few years to do some of this work. We're working with patient advocates and community advocates, health systems, and systems modelers to ask, what are the different components of the system that need to change? And what could we predict from that? And then based on that, what our real hope is that we can engender real partnership between communities and hospitals to do this in a more equitable way. Finally, just sort of in closing, we're doing cancer science in the community, right? We engage our communities drive our priorities, and we in turn give back to communities what we find. I feel like it's the only way to move forward in terms of equity is to really make sure that we're asking the questions that are high priority for our communities and that we work with them to formulate solutions together. Again, sort of want to leave you with cancer affects all of us, and for that reason, working together is just the only way to go. So thanks so much for listening. I think we're going to go to the Q&A. Again, I hope just make sure you get if you have questions, raise your hand. We'll get the mics going, and I hope to have a conversation. Many of you work in these different areas. I'm interested to learn from you. So with that, let's get started. And I think the folks with the microphones are in the back.
As a policy, we tend to gravitate towards more expensive treatments. One example would be for prostate cancer. Mm-hmm. So we've moved from normal radiation to proton therapy. Mm-hmm. And initially, the instruments for proton would be $500 million. Now they're about $100 billion. Mm-hmm. But even when initially it was a 10-to-1 ratio of cost, the efficacy of both is within about a 2% difference on outcomes. So once we have agreed to pay for proton therapy, we're paying a whole lot more money for a treatment that's basically very, very similar outcome. Mm-hmm. And so as a public policy, should we not be creating incentives for people to choose a less expensive but equally productive treatment?
Yeah, it's a great question. I think it's twofold, right? So there's that the one end is the consumer side of it, right? Should we be educating consumers better about is there really a difference? Is this a me too? Is this actually better than what you have? And do you want to sort of angle towards a thing that saves costs but still gives you sort of the best possible care? But I think the challenge starts even before that, right? I think there's been a resistance, particularly in our country, to really look and do comparative effectiveness analyses across different types of interventions to ask the question, okay, is it worthwhile? And we do comparative effectiveness analyses, but we've waxed and waned about our willingness to use that for policy purposes. And I think that's problematic for us. I'm not quite sure what the concerns are, and I'm sure people who sit on the other side could probably tell me what some of those concerns are, but I think we're really sort of hindering ourselves by not having full information about what is that a meaningful difference, right? Like if it's a 2% difference, is that meaningful? Sometimes yes, sometimes no. Is it clinically meaningful? Is it statistically meaningful, right? Those two questions have to be asked. So I think there's a number of places along the continuum where we need to ask that question. And I'm not opposed to cost containment. You know, I've worked with health systems, I understand it. We can't just sort of spend willy-nilly. I think a lot of the work that we've done is trying to understand, is this particular cost containment like prior authorization doing what it's intended to do? And if it is doing what it's intended to do, does it also have unintended consequences? And you have to balance those things. So we always, and again, in addition to working with patients and clinicians, we also work with health systems and other policymakers to make sure that we're being fair and complete in our review of things. And prior authorization is one of those things. It's like been a little bit clunky as a policy. It would be great if we could get it right, because I think it's a very handy tool. It's very effective for shifting things around in terms of utilization. It's just it shifts things around in a way that's it's a more of a blunt instrument right now, and so I think a lot of the policies that are coming out from the states, as well as CMS, are trying to get a little bit more refined there, so it can be a little bit more like a scalpel and a little bit less like a hammer.
Right. Dr. Adams, what an inspiring talk. Thank you for the work you're doing. My question is about the intersection of policy, regulations, and AI technology. You know, when we look at the 950 clearances from the FDA on AI, a lot of that is in radiology around imaging. And what we're increasingly finding is a lot of bias and inequity in the data sets that were being used. And as a result of that, the care has a lot of bias and inequity around it. So what can policymakers and regulators do to continue to encourage the technology to move forward, yet balance these biases?
It's a great question. So our human-centered AI group is doing a lot of work in this area. My colleague Michelle Mello is one of the leading experts in the world on this space, especially on the regulatory side. We do a boot camp every year for congressional staffers, and we just had ours back in, I can remember when it was a couple months ago, I think. And what I told them was one of the things that we need to do, just sort of just a base level to start at, is look around the room and see who's in the room when we're having these conversations and we're developing these policies. 9 times out of 10, there are very few patients. They may have one patient on the panel. It's not enough. We really need to have a better understanding, not just patients, but clinicians. Anyone who's going to be affected by the technology should be in the room. And we've learned so much by doing that. When in terms of the development of our own AI algorithm, we have patients in the room, we have clinicians in the room, and we ask them all the time, are we going the right direction? Where are the pitfalls? What are we not seeing? And they've really helped to direct us and sometimes help us rethink sort of the application of such algorithms because we're thinking about and concerned about both equity as well as ethics. Right? And equity sort of is a component of ethics in some ways, but really they've helped us to articulate that more clearly and be more directive. Again, the cat's also, I don't have cats out of the bag, this bad metaphor. I think what I'm saying is the horse has left the barn in terms of AI, and I think that's one of the struggles that we have, right? Is that once you create it, it's out there. The reality is slow adoption of AI in health systems is, all over the place. So we're building a lot of stuff. Either it's not useful or it's too challenging to use. So I'm a little bit less worried about that application. The one exception I would say is in risk management. That's where it's being used tremendously, and there's a lot of bias. right? And so there are others too who are fighting for ways, like Sherry Rose is an expert in looking at bias in algorithms and trying to assess that bias. And there are others trying to get a better handle on how do we improve the data to start with. Here at Stanford, we have what they call SOGI, so we're basically trying to do better data collection on the front end so that the data get better. But in the interim, we're in this squishy area where the data aren't great, we know they're biased, but we feel like we need to do something. And so that's why we need ethicists, that's why we need patients and clinicians and others who are affected by it in the room so that we can at least be aware of what we're doing so that we have a little bit more awareness of the potential consequences.
I want to go back to the slide that you showed early on about sort of the disparities and outcomes, and pretty striking.
Yeah.
But I think that was all national data. And my question to you is, we got 50 states and a lot of different counties and cities within those. Are there any places that are getting better outcomes that don't have those at least as bad and maybe don't have much? And what are they doing right, and how can we learn from that nationally?
It's a fantastic question. And I took out my detailed like county level, county to county slides. There's so much variation. Like so much variation out there. And we talk about positive deviance, right? These groups were like, they should be failing, but they're not, right? And trying to understand from that. So we're doing a lot of work now trying to work primarily with localities that are doing interesting things to see if we can formally test some of these experiments to see what the impact is for these patients. So there's a lot of work. You may have heard guaranteed income experiments. There are earned income tax experiments. There's a lot of different types of things going on at the local level that are interesting to look at. So other people, I don't particularly do a lot of positive deviance work myself, but I'm fascinated by it. There's some folks at Berkeley who I think specialize that, looking at individual communities to try to understand like what's different in some communities versus others. There's all sorts of theories, and that's why I feel like it's really helpful too to look to other disciplines. So sociologists might have something to say about what's going on. Like there's a lot of different types of things. One example is during COVID, there was a lot of conversation about groups who should have been doing worse than they were, if you just looked at the numbers. And so some of those questions were, to what extent is it that these groups are, they may have issues with in terms of income and education, but they're activated. And they're really working very closely with their health systems, or they're working very closely with the localities to make sure that things are set up in certain ways. Is that the secret sauce, right? Like, so there's a lot of conversation about that. It's not my particular area of specialty, but I think it's fascinating.
Hi, Dr. Adams.
Hi.
Thank you for the presentation. My question is around the ARPA-H grant that was awarded by the Biden administration in August. That was $150 million for this moonshot mission to eradicate cancer. My thinking originally was like, that's a very tiny amount for the magnitude of the problem. So my two questions for you are, one, what do you think needs to happen with this type of funding source? What other types of funding sources do they need to activate to potentially accelerate more technology, more talent, and more interest in solving this problem? That's one. And two, what do you see as the major technological challenges that is preventing us to have a viable solution that's long-term and effective?
Wow, it's a great question. I'm not going to pretend that I can answer all of that convincingly. What I will say is when they brought out ARPA-H and sort of sent it around, they usually do this, right? So they're gonna send out legislation. They usually send it around to get some thoughts about it. There's an open comment period. And so I'm part of Academy Health, so I'm on board of Academy Health, and I think I was chair or past chair at the time that ARPA-H was coming through. So it's our job really to review it and give advice about what we think should go on. I will say at that time, our public comment was that it focused way too much on treatment and less on prevention. In addition to that, it really was very biomedical. There were not conversations about community interventions and these kinds of things that you absolutely need if you're really going to have a big impact in cancer. There's so much about cancer that's about managing risks and getting people in early and get all of those things. None of that has to do with taking a pill, right? And so that was our advice. it didn't land, apparently. I suspect, like most things in policy, that there were negotiations that were had, and that's what they ended up with. It's a little bit like, watching sausage get made. It's a little unappealing, and you sort of get some good stuff at the end, but it's hard to sort of trace it back and figure out how you got there. So I think probably some people who study politics could tell us more about exactly what happened with ARPA-H. There are other pools out there. So the Patient-Centered Outcomes Research Institute, PCORI, which was started under Obamacare, essentially created PCORI, and it has a lot of bipartisan support now. As an entity, and it really focuses on patient-centered outcomes. They really have pushed everyone to do more engagement of patients and communities in the work that's done. And they have a separate budget that doesn't go under the same appropriations process as the NIH budget, for example. And so I see that as a real opportunity, because when you separate a little bit from the politics, right, you can get people talking about, okay, what are we trying to accomplish together? And I think that's what sort of they did for PCORI by separating out a little bit. So there's some interesting things happening there. But yeah, I couldn't tell you sort of what the end solution is for that. I think it's an ongoing struggle for all of us.
Dr. Adams, I have a question following back to the gentleman's first question about proton therapy.
Yes.
I'm going to approximate 5 or 10 times the cost and 2% difference in the benefit. How do consumers and patients figure out all that stuff? Because healthcare is one of the variables in my panoply of choices about how to spend my time and my money. And particularly if I've just been diagnosed, I don't have the bandwidth for that. So translate and best practices, please.
Absolutely. So one of the great things that PCORI did is, because they know they needed to, it was part of their mandate to work with patients and caregivers and families. They actually started, I don't know if you've heard of PCORI ambassadors, but they started a training program to help prepare patients and caregivers and families who wanted to do this to become experts in working collaboratively with researchers and others to sort of ensure that the research was following the needs and priorities of the patients. Similarly, there were groups that started that some of these were PCORI ambassadors. They got trained by PCORI and then opened up their own shops, if you will, their own nonprofits, and they're training others. And some of them expanded out, like my friend Libby Hoy, she runs PFCC Partners. They actually train caregivers and patients to work more collaboratively with health systems, to be able to influence decision-making at that level. Because as she was, I hope she doesn't mind telling me a story a little bit, but Libby was somebody who was in high school. Her mother was diagnosed with breast cancer, late-stage breast cancer. So overnight, she went from being a regular high school kid to navigating the healthcare system. Her dad had to work, so she was at the hospital trying to advocate for her mom, going to school, trying to keep the house going, all of that stuff. Later in life, she had her first child. He was born with significant what's the word I'm looking for? Disability. And so she had to go negotiate again as a mom. Flash forward several years ago to when I met her as a patient, she was diagnosed with head and neck cancer. And so all this is on, I'm giving up HIPAA, this is all up on our website. But she then had to become an advocate for herself for the first time, right? And I have learned more from Libby. And I'm not a patient, but I've learned more from Libby about how to work successfully, build infrastructure for patient and community engagement than from anybody else. She's amazing. And there are other Libbys out there, but there are patients who are doing this for others. So when they understand not everyone can do this for themselves, not everyone has the time or the wherewithal or the ability. So the training where they can and then providing that support. So there's groups out there who can help with all of these. And of course, there's the American Cancer Society, which is a tremendous partner of ours and has just a ton of information for patients. And there's people, like my friend Juanita Wash. She and I were here at Stanford giving a talk the other day because she does a lot of our AI work with us. She is a cancer survivor, and she spends a lot of her time, even though she's retired, helping other cancer patients navigate, particularly those first few months of like, what do I do? How do I think about these things? She's there for them. She's, calls in the middle of the night, on the weekends, whatever's required, she's there for them. And she's training others to do the same because she realizes she's now 75. She's not going to be able to do this forever. So she's over in the East Bay with Black ladies advocating for cancer care, and they're training up as many people as they can to be lay navigators for other patients. So that's the hope for me. That's really what I'm excited about, is what communities are doing for themselves and how can we support them to build capacity to do that.
Can you comment on the research that's done trying to develop individually oriented cancer treatments and whether they're reaching successful points that would direct us towards something that would be unique for me if I needed it, as opposed to just a generic solution for a general cancer?
Yeah, so this is not my area of research, I should say. So I don't want to go too far into the details because I'm not trained in that. However, personalized medicine really is something that we're doing a lot of. We call it precision oncology. The dean of the School of Medicine has a lot of work in this area, but the idea is to, not oncology specifically, but just in general in terms of precision medicine, the idea is to take what you know about the individual, particularly related to genetics, and to tailor that to what their treatment would be. So there's a ton of work going on in that space right now, in particular for people with advanced cancers. So these are folks for whom the standard treatment didn't work. So because the standard treatment didn't work, they're sort of saying, okay, let's see what we can do for you based on really digging down and saying, okay, exactly what's going on with your cells, what's really triggering this, how might we target what's going on in terms of cell therapy, for example, immunotherapy. Tons of work going on in that space. I think what's interesting about that is it's catalyzed. In the past clinical trials, it took a long time to get from mouse models to something that was ready for people to use, right? In terms of clinical trials, you had to go all through these different phases. Now with this more personalized medicine, we're finding very smaller groups in terms of the clinical trials, smaller groups of people that have been tested. And we're finding evidence earlier on, sort of like at stage 1 or 2 instead of at stage, sort of the stage 4, the clinical trials process, not the cancer process, the clinical trials process. So now we're seeing opening up of ideas, okay, if someone's really struggling, should we wait? Should we go ahead and start? So there's a lot more variability now in terms of how that process works and when things become available to people. So yeah, there's a ton of, I would encourage you to go to Stanford Cancer Institute website if you're interested in learning about specific types of cancer, is some of the stuff that they're doing, but it's quite remarkable, some of the advances that they're making, especially in recent years.